Okay, everyone, I'm going to get started because I've been warned by the powers that be that if I run over, it will be my head. So I want to thank you all for coming today, because I think this is a topic that has been something not within our departmental consciousness for a while. And as some of you are aware, we've had a couple of cases of suicide that have presented to the emergency department recently that have had catastrophic consequences, not just in the human toll, but also in terms of professional well-being for our group. And so I think it's important that we touch on this and come at it from a new angle. So I've been very, very privileged that I've never personally been touched directly by suicide. I know that's not the case for everyone. And I've been very, very fortunate to talk with someone with lived experience and be able to get some insights from them. And so I'm hoping to share some of that with you today. And like I said, come at this from a new angle. So having spoken with this person, they were incredibly helpful, incredibly insightful. And basically what they told me was, I didn't want to go to the emerge, but I had nowhere else to go, and I had to be safe. It was a last resort coming to our department. And I think if you asked a lot of our patients who are coming in with suicidal ideation, this would be a pretty common theme. I don't have empirical data on that, but most of them don't want to come to see us. They're in a place of desperation, of turmoil, and we are the last resort. And very often we are the only resort after banker's hours. So I want you to think of times that you or a loved one has been depressed or in a period of turmoil, and consider some of these important numbers. Suicide is the number 2 cause of mortality for all Canadians aged 15 to 34. It is the number 9 cause of mortality for all Canadians overall. Every year, over 4,000 Canadians successfully commit suicide. And that's probably grossly underreported due to persistent stigma, due to reporting issues, due to systematic bias. So, on that note, one death by suicide. Well, if you look at the numbers that come out of Health Canada and the Public Health Agency of Canada, for every successful suicide, there are 5 unintentional injuries. And we very often see those patients in the emergency department. And sometimes we're very successful at flagging them as having been the result of a suicide attempt, but we miss a lot of them. For every successful suicide, there are 25 to 30 attempts. Very often those are the patients we're seeing. And then for every suicide, there's 7 to 10 persons who are profoundly affected. Family members, spouses, good friends that will carry that life with them for the rest of their lives. This has a dramatic societal impact. The estimate says anywhere in the $3 billion a year for Canadian society in terms of lost productivity, income, healthcare costs. So we've talked about Canada. What about Vancouver? Well, every year we see about 1,500 patients at St. Paul's presenting with suicidal ideation. Every year. And this has been stable for the last 4 years. Before that, it was climbing, and that correlated with our annual increases in visits. 1,500 patients a year coming to us in absolute turmoil. And regionally, we're seeing about 5,000 patients a year for coastal. I don't have Fraser Health data. That is a staggering number of patients. So my question to you as a group is, how can we work to improve care? Because I think we do some things very well, but I think we can do better. And I think we owe it to our patients to do better. So, issue number 1, screening. Okay? So some of you hear the word screening and you think about, oh, someone comes in with suicidal ideation and I want to figure out whether they're high risk or low risk and I can send them home. You know, to paraphrase one of my colleagues, the troponin for mental health. Okay? That's not what I mean by screening. By screening, I mean 40% of patients who successfully commit suicide have been seen in the emergency department within the year previous for a mental health complaint. There's a huge opportunity there for intervention and improvement of care. In addition, of patients presenting to the emergency department with known risk factors for suicide, only 5% are successfully screened for potential suicidal ideation. So for the residents and learners in the room in particular, I want you to think about what we screen for on a daily basis, not just in our primary care settings, our emergency departments, but in all walks of medicine. When every patient comes into the emergency department, whether it's to a monitored bed or a RAS bed, fast track, and they interact with one of our nurses, they're asked about, do you smoke? Do you drink? Do you use drugs? For women in particular, do you feel safe at home? Have you ever been threatened? Have you ever been assaulted? Why are we not screening for suicide? So the next big question is systematic screening in the ED feasible? And to be honest, no one's ever explored this. There's one study, that study that created the 5%, one retrospective study from the United States that says, yes, we might be able to do it. So this is an avenue that we are embarking upon with our research partners and our team to explore the possibility of, is systematic screening in the ED feasible for suicide and suicidal risk? We've been very, very fortunate. We've received some funding through the foundation to help support some of these initiatives, and I'm going to touch on some of the future directions as I move through this presentation. But just to let you know that this is something we're going to be exploring, studying, and trying to implement in our department over the next few months. Now, coming back to the idea of risk stratification, you know, some of you say, well, if someone's coming in with suicidal ideation and they're not intoxicated, they're not altered by substance, I just want to be able to get a quick score and say, low risk, send them home, outpatient supports and follow-ups, or high risk, they need to be certified, they need to see psychiatry. And I'll be totally honest, for a long time that's the way I thought. It's a binary decision. They need to stay or they can go home. Unfortunately, I love the formatting. There's about 9 to 20-something odd suicide risk severity scales that have been developed, that have been trialed, that have been potentially validated. And you're really trying to focus in on that 1 or 2 patients that you think might benefit from going home quickly. They don't need to stay in the emerge. You've been able to provide that element of safety and support to get them home safely, but with appropriate coordination of care. However, and this comes from the latest ACEP position statement of care of the psychiatric patient from 2017, there's unfortunately no tool currently available that can solely be used to predict the risk of suicide among patients presenting to the emergency department. There are 2 active randomized trials ongoing, one in France and one in the United States, to try and develop improved screening tools with robust psychometric properties, but they're ongoing. We don't have the results of those yet. They haven't been validated at other sites. So right now we're still in a bit of a state of limbo in terms of what tools we have to risk predict and risk stratify these patients. And this is assuming that they are sober, not impaired by substances. So one of the questions that I get asked by our learners a lot is, does this patient need blood work? Even in my training, I had very conflicting things told to me by staff about blood work for the patient presenting with a psychiatric complaint. Okay? You're just looking for a needle in the haystack. Don't waste your time. Okay? Should routine tests be used? So, does anyone know this location? I'm going to give you a hint. It's in London. Yes, Broad Street Pump. You're cheating. You're an epidemiologist. So this is the Broad Street Pump in the Soho district of London. The other picture I have of it is with my kids standing beside it, and there happen to be two very intoxicated Londonites who are sitting there having their pint and I think actually rolling a joint. So we didn't include that one in the presentation. But it brings me back to my epidemiologic foundations that the evidence is poor to support foregoing medical workup. The latest ASAP position statement includes 4 retrospective studies, and they're only patients that were admitted to inpatient psychiatric wards. They were not patients that were either discharged or sent to other medical services. And the level of evidence is really weak to forego routine blood testing in these patients. The ASAP statement does strongly recommend routine blood work in the elderly patient, the immunocompromised patient, the patient with new onset psychosis, we don't see any of that, and substance use. So for me at least, those 4 bottom points, that makes up a substantial proportion of the St. Paul's and regional psychiatric population presenting to the emergency department with suicidal ideation. So foregoing blood work in this patient population is, I think, a very risky proposition. I'm not advocating $1,000 of blood work, but CBC, electrolyte profile, maybe TSH, maybe some toxicology included. Use your clinical judgment. But this is the current state of the evidence with regards to routine blood testing for this patient population. So coming back to the question of about how can we improve care. So we've talked about screening, we've talked about blood work. Over and over and over, when you read on patient experiences of coming to the emergency department with a mental health complaint, one of the big things that comes out over and over and over and over is the stigma associated with coming to the emergency department. Whether it's stigma from other patients, stigma from family, or stigma from us, from care providers. And there's actually evidence that for pediatric patients that get labeled with a mental health diagnosis coming to the emergency department, their care is different. We have built-in biases against patients with mental health, and unfortunately it's something that we've been inundated with through our training and through our culture over the last 20, 30, 40 years, that we treat these patients differently. And that is something that I think as a group we can work to address. And that comes back to one of Simon's key points about empathy. This is akin to someone presenting with a STEMI. This is akin to someone presenting septic. These patients are some of the most critical, dependent, vulnerable points in their lives, and we can do better. So the next aspect of that is how can we improve the patient experience? So, Bicêtre Hospital, Paris. I know there's 1 or 2 people here that know Paris quite well, just in the Gentilly district south of Notre Dame. So Bicêtre Hospital is quite interesting from a psychiatry perspective and from a taking good care of patients perspective. So there were 2 psychiatrists at Bicêtre Hospital in the late 1790s. One of them who, if anyone has worked or lived in Montreal, will know the name Pinel. So Pinel was one of the psychiatrists who worked there. And they did something that we would probably see make sense now, 200 years later. They hired patients to help take care of patients. The very beginnings, the very origins of the idea of peer support. So peer support is a bit of a novel concept for us in the emergency department. Other aspects of medicine have been embracing peer support for the last 20 years. Oncology, addictions, cardiology, they've had peer support workers embedded in their clinical care for almost 20 years in some places. And we're just starting to take note of that now. And basically what peer support is they're trained professionals who undergo rigorous training They learn all about confidentiality, respecting privacy, and they can act as mentors, guides, navigators for patients coming in with mental health complaints. Our Rapid Access Addictions Clinic has successfully used peer support workers for the last couple of years. And so, with assistance from the Foundation and from the Mental Health Services team, we're going to be actually incorporating a peer support worker for patients presenting with mental health complaints in the emergency department in the very near future. And this is actually something that patients have identified as a key priority for them when they come to the emergency department. They want someone with lived experience who can be there with them to help guide them through some of the process. So the next key question, and I know this is sort of a novel concept for some of us, is should we be following up with these patients after they present to the emergency department? You know, we follow up on blood cultures, we follow up on throat swabs. Someone goes home, radiology calls us the next morning, oh, they have a tiny little blush on their CT head, I think they might have a subarachnoid. We get them to come back toot sweet. This is no different. It does require a bit of a shift in mindset for us because we've never really done this here. So there are different options. Right now we are blessed. We have very good outpatient hospital resources. Patients can come back to the BIC. They can come back to AAC at VGH. We can phone them. We can pick up the phone, whether it's us or someone in the circle of care can call them to follow up on them and see how they're doing. And we can meet them out in the community. It can be a clinic. There's a one-stop shop, low-barrier access point for youth called Foundry. I know some of you have heard me talk about it. Over on Granville Street, there's one on the North Shore, and there's several others around the province. There are other community resources, whether it's mental health teams or low-barrier community access points for mental health follow-up. But I want you to think about the ED element for a little bit. So if I could offer you a potential 20% relative risk reduction in suicidal behavior within a year for a patient presenting with suicidal behavior, that's a number needed to treat of about 13 to 20. That's better than ASA for acute MI. That's comparable to non-invasive positive pressure ventilation for COPD exacerbation. Highly effective therapy to prevent recurrence. So, very smart group, very active, coordinated group out of Harvard Brown and UMass Worcester did a study called ED Safe. And they basically had three key elements. A 2-question suicide screener by emergency physicians, in addition to whatever was done at triage. So the emergency physicians asked 2 standardized questions. The patients were provided with a self-administered safety plan that they completed, they wrote while they were in the emergency department, and they were able to take home with them. And they had follow-up phone calls with PhD-trained psychologists, fellows, or clinical counselors. And they could receive phone calls, anywhere from 1 to 6 phone calls, lasting up to an hour, up to 1 year out from their initial presentation. And this was a sort of a coordinated theory and evidence-based intervention. And 20% relative risk reduction in suicidal behavior at 1 year. We do much lower yield things for much less common and significant health problems than this. So this is something that we are working with the Foundation and our research team to try and implement over the next 6 months or so. And it will be part of this overall strategy in terms of improving care for the patients presenting with mental health concerns to the emergency department. So I bring you back to sort of my key question of how can we improve care, but also how can we improve patient experience and policy? So we've touched on systematic screening in the emergency department. We're going to try and start doing this, but we're also going to be studying it to see if it's feasible, working with our team of nurses and other allied health professionals in the emergency department. I think the stigma that I touched on is something that, as a department, we are already very good and receptive to working with marginalized and disenfranchised populations, and I think this is sort of the next key frontier for us, is working to reduce any potential stigma to patients coming in with mental health concerns. We're going to be implementing and evaluating peer support. We're going to be implementing and evaluating follow-up. And I think not just myself or departmental leadership or hospital leadership, but we should all be looking at how can we advocate better for system change for our patients. We are all going to have friends and family members who go through mental health crises in the next 5, 10, 15 years and the rest of our lives, if you haven't already. And it behooves us as the advocates for patients that we are to advocate for these patients. We need to speak up, whether it's to hospital leadership or regional leadership or provincial leadership, and advocate for these patients for better care, for better resources. I want to thank you very much for your time. If you'd like any of the references or resources for my presentation, email me. They're all in a workspace folder. Okay? And I will turn the lectern over to Mathieu very shortly. If anyone has any comments or questions, I'd be very happy to take them now. Yes?
The issue of screening, are you not concerned about the Pandora's box? Then don't you have to create
That's a great point. That's a great point. Yes. So, I mean, you do raise a very valid point, and it's something we've discussed at length with the leadership from mental health, that our current capacity to rapidly follow up a patient who endorses suicidal thoughts may be currently at its threshold. And so that will be a work ongoing to figure out the best way to effectively provide them with rapid follow-up, whether it's through BIC, whether it's through AAC, whether it's through emergency department-based resources, what primary care, what's the best avenue if all of a sudden we're identifying 20% of our patients with suicidal ideation. We have no frame of reference. There's nothing out there in the literature in terms of the systematic screening of emergency department patients, not just patients with mental health issues, but all patients. And the only study that I know exists is that one that quotes 5% of successfully screening them. So.
Thanks, David. That's really interesting. A number of years ago, I did a retrospective data review where I looked at patients who've been in St. Paul's Hospital over a 5-year period of time. The ones who were not at suicide rate. Your attention, please. With Glenn Beard, please ask staff member to help him call the clinical coordinator's office. Would Glenn Beard please ask any staff member to help him call the clinical coordinator's office? Would Glenn Beard please ask any staff member to help him call the clinical coordinator's office?
Well, that's probably the strangest overhead page I've ever heard.
Anyway, the 30-day suicide rate was about 0.4%.
Yeah.
So a 20% reduction in that, like, that's a lot of screening and a lot of work to get what might not be a huge risk. And one of the things about screening for things like HIV is if we find those people and we can treat them, then they, they go on with their lives. It's not entirely clear to me what interventions for suicidal ideation are that actually make a difference, because it's such an in the moment kind of thing you can find.
So I think you raise a good point, and you speak to several issues within the system. I think, unfortunately, some of the patients we see become suicidal due to acute substance misuse and alteration of their mood. However, the overall public health impact of suicide is not debatable. And we screen for far less benign issues on an everyday basis. We ask patients whether they smoke, whether they use drugs, whether they are victims of intimate partner violence. And I'm not trying to downplay any of those conditions. They all have dramatically profound impacts on patients' health and long-term outcomes. But in terms of a potential public health benefit, that screening that we do in the emergency department, the provision of a tetanus shot to someone with a small scratch on their finger, in terms of public health intervention, is absolutely negligible in terms of our potential benefit here. Even if we were just to focus on one age group, we have rapid access to low barrier treatment and supports. 1,500 patients a year alone at St. Paul's is, where is it? That's just St. Paul's. That doesn't include MSJ. Does not include the rest of VCH. I mean, to me, that in and of alone, of the 90,000 patients we see every year, we saw 89 sick last year. Of the 90,000 patients we see a year, that's almost 2% of them.
Hey, thanks to both Dave and Simon for touching on issues that we don't normally touch on. And I'm also going to say, this isn't mentioned very often, but two very visually appealing presentations, by the way, as well. It's clear a lot of work went into this. This is, if you look at things like AFib or cardiac arrest, I think our care has improved dramatically even over the past decade. If you look at our treatment of mental health, I could not really make that statement. In my residency training, I spent my family medicine training, I spent 2 weeks in outpatient psychiatry. I don't know how much in 5 years you spend looking at mental health, psychiatric substance misuse issues. Hopefully it's getting better, but the training just isn't really there. The fact is also, 1,500 patients present. That's their chief complaint. How many patients show up with abdominal pain a couple times as sort of their way of showing up, but they don't really want to say anything about their mental health issues? We already know that the people that show up here do have way more underlying mental health issues than just are floating around in the community. And they're not going to say, well, I feel suicidal. I might just say something hurts, and it's a vague complaint that you can't quite make sense of at 2 a.m. So there is a ton of room for improvement in this. This is probably along with substance misuse, this is probably two of the things that emergency physicians have the greatest potential for improvement. This isn't limited just to emergency medicine. We're just not taught this stuff in med school very well. And I think we have the combination of a patient population that is where we could work with this. And also we have a very, very supportive administration and a very supportive partnership with numerous agencies that we've worked hard to cultivate where we feel we can really make a difference in patients' lives here. If anyone has any feedback or any thoughts for the next few months, statistically speaking, many people in this room will have struggled with mental health issues themselves or know a loved one that has, and any thoughts are really, really welcome here. This is not going to be imposed by fiat as we're doing this, but we're looking for as many people to provide help and commentary and assistance that we can to improve our overall patient experience, not just here, but throughout the region of British Columbia as well.
Absolutely. And just to sort of add on to Frank's little point there, thank you, very well put. So one thing I knocked out last minute and decided not to include is the NACRS data that we have available from across Canada. Granted, NACRS is an incomplete data set, NACRS being the National Ambulatory Care Registry System. Last year, there were 1,800 opioid overdoses that were deemed intentional across the country. Granted, we probably saw half of them here, but a substantial proportion of our patients that use opioids, either due to addictions issues or elders who use them for pain control, will intentionally overdose on opioids. And of those overdoses that included opioids, 10,000 were mixed overdoses with other illicit drugs, not to mention things like Tylenol, aspirin, and other legally prescribed medications. So it's a staggering burden on the Canadian system. And I think it behooves us to work with our partners and build a better care for our patients. As Frank pointed out, and very appropriately so, if you are interested, if you would like to help, please just email me, talk to me. I've already had one or two of you who who have reached out and said, I'd be happy to work on this. The more insights, the more bright minds, the better, because I think we as a group can work towards providing better care.
Thanks, David. And just to echo Frank's comments, I think it's great you're tackling this, because when you think about all the talks we get here, over the last 5 years or more, there's so little devoted to mental health, or if we do anything, it's more about the flow and how do we get them out of our ED as fast as possible. It's not really about improving services. So I think this is great. I think the idea of outreach is also great, and maybe even dovetailing it with, if there is also substance use, to combine it with the overdose outreach team. So I think there are a lot of great possibilities there. So thanks for tackling this.
Cool. All right, I'm going to turn it over to Mathieu now, and thank you again very much for your comments and for your attention. So I'll show you. All right, so just pop yours in there.
Hello. All right, does that work? Yeah. Is there... No. No. Is there a way so I can get my notes at the bottom too? Or? Like presenter view? Or... Yeah. Okay. No. Yes, I can. Yes, might not be able to. Yeah, I'll figure it out. So hi, everybody. I'm Matt. I'm one of the R3s here, and I'll be talking about infiltrative cardiomyopathy and some equipment failure. So the whole presentation will be based on a case that I had in the emergency department when I was on CCU. So we'll talk about infiltrative cardiomyopathies, and the equipment failure will be part of it, and a small conclusion at the end. So the case was a 51-year-old female that was, main complaint was chest pain and syncope. There was a call by EMS before she arrived that she was under investigation for some heart problem, and that she had a pericardial effusion, and then she was tachypneic, bradycardic, and hypotensive. So the CCU team was called to come to the resus bay prior to the patient's arrival. And I was part of that CCU team. On arrival, the patient's BP was, the systolic was in the hundreds, heart rate was in the 50s, she was bit tachypneic at 25, maybe a bit cyanotic, and her sats were 80s on nasal prongs. She was afebrile, glucose was normal. She was also unilingual Turkish, which made the story a little bit harder, but she presented with her partner, and she was very drowsy. That's her initial ECG. That shows a very bradycardic rhythm, junctional rhythm. And that here's her initial chest X-ray. That shows a bilateral pleural effusion, more on the right than on the left, and a very massive cardiac silhouette. So the main infiltrative cardiomyopathies are cardiac amyloidosis, cardiac sarcoidosis, hemochromatosis, and other fancy disease like Fabry disease, Danon disease, and Friedrich's. Today we'll focus on cardiac amyloidosis because it was the working diagnosis that the patient was having as an outpatient with an outpatient cardiologist. So the presentation for cardiac amyloidosis can be very diversified. They usually present with the signs of right side heart failure. And pulmonary edema is usually pretty rare. It's mostly peripheral edema and ascites. They can have an ACS-like picture, but without any clear obstruction of the coronaries. They can have also syncope and pre-syncope, which is multifactorial, because their cardiac output is very dependent on the heart rate, and they have a fixed stroke volume. They're very dependent on their fluids. If they're a bit hypovolemic, have pre-syncope. They can also have weird arrhythmias or ventricular arrhythmias, which can cause syncope, and they have high-grade conduction disease also. They can have tamponade and thromboembolism with or without AFib, because the cardiac amyloidosis also predisposes them to atrial fibrillation. So initial investigations for people like this is an ECG that will show low voltage QRS, as we saw in the first ECG. They can have poor wave progression, QS waves. They can have AFib, A-flutter, ventricular arrhythmias that are a bit more rare. And then on ultrasound, if you do an echo or bedside, what you usually see is ventricular wall thickness, and you'll see that speckled appearance of the myometrium, which we can see. So on the left side is a normal heart, and on the right side is an amyloid heart. You see the ventricles are much thicker, and you see that speckled appearance of the myocardium. They usually have diastolic dysfunction, and then the cardiologist will send them for a cardiac MRI, and that shows late gadolinium enhancement. So this is the case that we had. A few images of the POCUS I would show. So this is a, oh no, QuickTime not available. Huh. Okay, well, all right. So this is a frozen video of what, so you can see the apical 4 and you can see the pericardial effusion. If you were to see the video, you can see that the walls of the ventricle are super stiff and they move together, and it's not like a contraction that's made with the ventricles. And you can see the two atriums are very, very enlarged on both sides. And then you won't see much on the other pictures, but technically this is a personal short, and you see the massive effusion here, and you see a bit of the ventricles here. And then you won't see this, but that's the right upper quadrant. You see the patient has ascites, but it doesn't work. All right, so because they've had a very diversified presentation, we'll go over some of those presentations and quick treatment for them. So for this patient, the working diagnosis, and the reason why we're called to bedside is because the patient might have tamponade because of that known pericardial effusion, that chest pain and syncope, and we're called for maybe emergent pericocentesis. When I was there, the cardiologist staff didn't believe it was tamponade, but still said if we believe that's the problem, we should give fluids. But actually, fluids seems that they don't change much in tamponade. It doesn't increase mortality or actually decreases mortality or decreases morbidity. And it might help, though, to declare the tamponade with the hemodynamics. Inotropic support for tamponade has uncertain benefits, and one also try to avoid positive pressure ventilation in tamponade because it might just make it worse. The only real treatment for this is drainage. And then you have to understand those two curves here on the side. So somebody who has a very fast accumulation of fluid will need much less fluid to create the same hemodynamics as a patient who has a very slow accumulation of fluid. Like this patient will need much more fluid to create the same hemodynamic compromise. And somebody who presents with atrial fibrillation, you want to be careful with beta blockers because, as I explained before, their cardiac output is very dependent on their heart rate because they have a fixed stroke volume. So you want to start low on beta blockers. You want to also try to avoid calcium channel blockers because they will bind the amyloid fibrins and they will increase toxicity. So it's kind of a relative contraindication. And you want to be careful with digoxin also. So you're going to go very slowly when you treat atrial fibrillation. So this is the treatment of heart failure. It's a super long slide from up to date, which we won't go over because it's too long. We'll just focus on some few things. So usually patients, this patient, when we did a bedside, had the reduced ejection fraction. So what you want to do usually is try to loop diuretics. This is for cardiogenic shock, not only for people who are very, very bad. And you want to try maybe inotropes initially for people that reduce ejection fraction. If they have a preserved ejection fraction, you want to be careful with inotropes because you might create LV outflow obstruction. And if you create this, then you want to treat with beta blockers. And you want to use vasopressors like norepi. And if you don't know what's going on, you can try inotropes and see what's happening. There's also a medication that we don't have here or in the USA that's called levosidimidam or sidinam that you might hear at some point. It's a calcium channel sensitizer that creates, that is an inotrope and also creates vasodilation. So maybe at some point we'll have this over here. And I looked at there was a Cochrane review in 2018 that showed no better combination of inotropes or vasodilators for cardiogenic shock. So if we go back to the case, our initial diagnosis or working diagnosis was tamponade, but because of the disease, you won't see the typical signs of tamponade on POCUS. Because of those ventricles that are so stiff, you won't see that collapse of the the right ventricle and diastole, and you won't see that right atrial cups because you usually have huge atrias. And they have chronic pericardial effusion, so even if you see an effusion, it might not guide you towards the diagnosis of tamponade, and they will also have a dilated non-pulsatile IVC at baseline. So now our differential was tamponade versus other things, and the patient was given a little bit more fluid, and the patient continued to deteriorate, and it was more and more difficult to keep her SATs normal, so it was decided to intubate her with rocuronium ketamine and a bit of phenylephrine because of soft BPs and more fluid. So the intubation went well, and peritubation, she had a bit of a drop in her pressure, so we started on norepinephrine peripherally, and then lines were placed for continuous treatment. And then these were her initial labs. CBC is pretty normal, INR is a bit elevated, LFT is a bit elevated, D-dimer is through the roof, troponin is a bit elevated, she's a bit acidemic, and electrolytes are pretty normal. So then post-intubation, SATs were normal, the tube placement was confirmed with the capnography and the chest X-ray.
Code yellow, stage 1, Providence, 7 Bravo. Code yellow, stage 1, Providence, 7 Bravo. Code yellow, stage 1, Providence, 7 Bravo.
And then a few minutes after she was intubated, her SATs started dropping to the low 50s and low 60s. So we got very worried, and we didn't know what was going on. We look at the platysmal graph, which is the graph with the O2 SAT that looked pretty normal. So like, well, this is probably a good SAT. And then we tried different sides, trying both extremities, tried the toes, tried the fingers, tried the forehead, tried the earlobes. It was always showing us the same SATs with the good waveform. And then we're like, well, is there a problem with her intubation? So we tried to look for displacement of the tube, repeated chest X-ray, did bedside ultrasound, no signs of pneumothorax, no signs of displacement. The RTs were playing with the vents, trying to see if there was any equipment failure. Nothing. Everything seemed to be normal, except those SATs that were 50s and 60s and good waveform. So we started to be very worried and thought about other diagnoses. So with the story of a patient that comes in with syncope, chest pain, and a dimer that's through the roof, the working diagnosis became PE. And since she was not looking great, it was decided to give her lytics. Peri-code dose of lytics, peri-arrest dose. And then we get our labs back, because at the same time we had an art line, so we're doing ABGs. And then we have those sets of 50s and 60s and a P with a good waveform, and we have PO2s of 196 and 180. So we're all looking at those labs and looking at the monitors and feeling a bit like Kevin Hart here. And it does, yeah, it works. That works. So then I asked myself, was the second case that I had as a CCU resident in 2 weeks of a patient that the O2 SAT monitors would show us SATs of 50s and 60s with good waveform, despite PO2s being over 100. So I was trying to figure out what was going on. And then an RT at some point talked to me about the Perfusion Index, which is a number on our Philips monitors that nobody really knows what it is. So I tried to look it up a little bit, because the way we're thought about to read the O2 SAT and see if we can trust it is to look at the waveform. And if we have a good amplitude, then it should be reliable, and if you have good tracing. So I'm in Whistler right now, and I met this guy. This guy is Joe Chiani. He's the founder of Massimo and current CEO of Massimo. Massimo is the company that does our O2 probes in the ICU, CCU, and those in the recess bay. So he was a great guy to ask questions to, because he could help answer my questions. So I asked him a bit, what about that perfusion index? And then he tried to describe it to me. So basically, it's the difference between the higher end and the lower end of that waveform. And this is the Philips monitor, and you can see the circle, the orange circle over there. This is the perfusion index over here. And we'll talk a bit more about all of those things a bit later. So the perfusion index is used in different other specialties in neonatal care to monitor care and over there. It's used also in anesthesia, but there's no good use for us in terms of predicting morbidity or mortality in the emergency department. There's no good studies for that. And there's one thing that we need to know about our monitors here at St. Paul. So the Philips monitors, the big ones that are in the recess bays, ICU and CCU, will auto-scale that O2 graph. So if you have a flat line or almost a flat line on another monitor, this monitor will show you a normal curve, because it will auto-scale and make it much bigger. So that might have been one of the problems that we had with our monitor. And even if they're Philips monitor, they use the Massimo technology, but they don't incorporate all of Massimo's indicators in those Philips monitors. So the Massimo monitors, we have one Massimo standalone monitor in the ED, which is with the RTs. will show you that waveform that is not scaled. So it will show you the actual waveform, and it will show you the little lines at the bottom that are called the single quality index. So if the lines are higher, it will tell you that the monitor is acute, not acute, but accurate. And if it's almost nothing, it will tell you that it's not really accurate, despite if the waveform doesn't look good. And then, so on our Philips monitor, so this is a Philips monitor. As I said, the perfusion index is over here, and can be from 0.02 to 20. Usually when it gets under 2 or under 1, you can less and less trust your O2 reading. And then there's that little triangle here that I didn't know what it was until a few days ago. So this is kind of the integration of Philips of that signal quality index or indicator of the Massimo technology. And that triangle will either be full, half empty, or completely empty. And if that triangle is completely empty, your number doesn't really mean anything. Despite you can have a super nice waveform, but if your triangle is empty, it doesn't mean much. And then there's some ways to try this. If you have people that have low perfusion states and you're having a hard time finding a good O2 stat, there's a way that you click on the monitor on the O2 number, and then you can go in settings and increase its sensitivity to maximum. So there's 3 settings you can take, and you can go all the way to maximum. So this is so going back to the case that we had, it would be nice to have been able to see the POCUS images, but the formal TT after showed what we saw in the POCUS, that the EF was a bit decreased, and it was typical of that amyloid presentation of that speckled appearance. And in terms of conclusion, for cardiac amyloidosis, I think it's important to remember that it has multiple different presentations, and it's difficult to interpret POCUS with cardiac amyloidosis. You have to understand what it usually looks like, and you might not see what you're expected to see for different disease. And in terms of our monitors, I think it would be important to have maybe more training about them and try to understand their limitations, because I had no clue about that waveform, and medical decisions were taken for those patients, trusting those monitors and believing they were telling us things that they were actually completely wrong, and the O2 stat was actually not reliable. So it would be a good thing for maybe people then to try to localize that little triangle, that perfusion index on the monitors. So I'd like to thank Dave Barbic for his help with the presentation, Karine Badra-Quirion for her POCUS images that we did not see. Shannon helped me also to try to get some information about that patient. And these are all the patients the people at Massimo that helped me. I have here today Rob Tujimira, who's with us. He's from Massimo. He brought some monitors. So if people have questions or more questions about the details of monitor, what we can look at them, he's here also to help me answer your questions. Thank you very much. Yeah.
So I'm not really clear. Was your poor saturation levels, was it artifactual, in other words, not real, or is it because poor cardiac output? I don't know if you can solve that.
So it was probably not real. But the thing that I want to say is we shouldn't have trusted those numbers, even if we had a good waveform on the monitor, because there was actually probably no waveform.
But what about that index? I couldn't see that.
Yeah, so I didn't, because those numbers are not, they're not charted. So I don't remember what was the number, but I remember thinking I was a bit low because it was my second case within a few weeks, and I didn't know about that triangle, so I have no clue if that triangle was full or empty. But all I'm saying is that maybe we should try to look at those things before we take medical decision that could be very detrimental to the patient.
We can also do a measured saturation.
So that's what we did, but then it takes time. So if your patient has a SAT of 50, do you really want to wait 5 minutes before you get your result?
Sure you do, because you want to, if it's wrong and you intubate positive pressure, you'll kill it.
Yeah, sure, but she was already intubated.
Anyway, she waited more than 5 minutes because she got a TE and a million other tests. So.
No, the T was much later. Yeah. Because if you have a patient that's not looking good in front of you and you see SATs of 50 or 60s, how long are you ready to wait? Any other questions? All right, thank you very much.